convention. And he
Right
said,
on.
"Oh, do you want to
Right
go
on.
later?" I said, "No, I got to run out to the train."
All right,
I'll
so
go to the train.
let me just start with basically what is exactly addiction? Right? What is exactly addiction? One of the clear things, okay, we have to understand, DNA was described in the 1950s, 1953. You got to keep in mind that, you know, the whole AA recovery 12-step movement, and I'm a huge 12-step advocate, but it started back in the 30s, right? A lot of the changes that happen in the brain we did not know about until, let's say, 10, 12 years ago. Nora Volkow over at the NIH, she did a lot of the initial groundwork showing us that the brain literally changes. The brain literally changes. So addiction is a result of adaptations in the brain that lead to changes in the behavior, right? So in the frontal part of the brain, which is the executive center, the brakes don't work. The brakes don't work. Now, does that mean it's true for everybody? No, it does not, right? So the people that make it into the office are a different subset of clients or patients, right? There are people that can stop on their own, but those aren't the people that are coming into the office, right? These people are unable to, due to nature, you know, or nurture, either way, you know, genes or the environment. Now there are certain things that make it more likely, which we'll get into, but basically addiction is a result of these changes, right? And the way I like to even further think about it is not just the DSM-4 criteria, well, which includes some of it, but it's that craziness. It's all the lying, the stealing, not going to work, not staying on task, all that behavior that destroys relationships and families, right? That to me is what addiction is. Actually in the DSM-4 TR, they don't use the word addiction, right? They use dependency or abuse, right? So once it goes from misuse to abuse to dependency, you got a new baby. It's literally, you got diabetes. Just say, like saying, you have high blood pressure, you have a disease. Now we have to be careful that we don't say, well, that's a good that's the reason someone relapsed. You know, that we don't use that as the reason to relapse, right? All right. So that's what addiction is. Now, genes versus environment, it's always both, right? There are different vulnerabilities in different families. You can take two identical individuals that have, say, schizophrenia in the family, in the first-degree relative, one of their parents. One gets it, one doesn't, and they're identical twins, right? So clearly, we know that the environment makes a difference, but so it's not just the genes. It's not just the genes. Some environments that do put you at higher risk, well, stress, of course, right? If you live in a, let's say, downtown Washington, D.C., and they're selling heroin on the corner, that's a problem. That's a very stressful environment. So stress, drug availability, abuse, if there's physical abuse in the house, if there's mental abuse, sexual abuse, all these things, of course, are going to increase the likelihood that that young person is going to want to self-medicate, right?
Right.
And of course, the earlier you start, the more likely it is that these changes will take over. In fact, there's some really good research out of Columbia that shows us that just looking at actually what we're doing what all of you are doing right now, having dinner. If you, families ask me, well, what should I do, doc? What can I do? The parents ask me, right? If you look at, they took two groups of people. They told this family had 0 to 2 family dinners per week. Group number 2, 5 to 7 family dinners per week.
No.
Just by the fact of having dinner together, substance abuse rates are lower in that group. You don't tell them what to talk about. You don't tell them what not. Just by sitting together, substance abuse rates are lower. Because you're going to say, hey, Johnny, what'd you do today?
Stress.
You know, by the way, I don't like your friend Alex, right? It's et cetera, et cetera, et cetera. It creates that communication. So I always, when they ask, I say, have dinner with your kids. That significantly makes a difference, right? So why do people use drugs? Why do people use drugs? Self-medication, number one, right? Now clearly there's a lot of dual diagnosis clients. What is a dual diagnosis client? A dual diagnosis client is somebody who has a psychiatric disorder plus an addiction disorder, right? So somebody, say, who has panic disorder and takes some kind of a narcotic, and they say, wow, my anxiety went away. So now that as soon as they develop a dependency, now you got two problems, right? So self-medication, recreational use, of course. These are a lot of the college kids, a lot of the high school kids, a lot of what we're seeing with the opiate. In fact, the opiate use in New Jersey. I don't know how many of you are aware that there are more opiate-related overdose fatalities in New York, New Jersey, and Connecticut than those caused by motor vehicle accidents. Actually, and then there's 14 other states. So there's 17 total states, and the CDC is suspecting it's soon going to be the number one cause over motor vehicle accidents. That to me is like an amazing thing, because we hear a lot of people, get into accidents, and this is a significant problem. Performance enhancement, right? People say, well, I know my neighbor's kid is, on a stimulant for ADHD. I think my kid has it too. So over, this kind of performance enhancement use, obviously that involves inappropriate prescribing by that physician too. So doctors are part of the issue as well. Doctors are part of the issue as well. But I think the DEA is really stepping in and starting to do much better monitoring. We have a wonderful monitoring program in New Jersey now, actually. You can look up someone's name and see how many people, how many pharmacies somebody's been at, right, what they're getting filled, and so forth. But back to addiction. The neurotransmitter, or the neurochemical that you need to think about is, you want to write on the back of this?
I have my paper, but it's a collateral process. How do I get in touch with that process to be able to check what a client's using? Can consumers like us have access to that?
I got the website.
Yeah.
Thank you. Okay. I'll follow through with this. Thank you, doctor.
So now with dopamine, okay, so what is dopamine? Dopamine is one of the main neurotransmitters involved in addiction, right? Dopamine is one of the main neurotransmitters involved in addiction. Every time you take a bite of your food, tastes good, that's a little bit of dopamine being released, right? Sexual reproduction is linked to feeling pleasure, that's dopamine. So the pleasure reward pathway is dopamine driven. Now, it was not meant to be flooded with dopamine. And that's part of the problem, right? It was meant to make sure that we as a species do things, eat, reproduce, etc., that are going to help us move forward and as a race, but it wasn't meant to be abused. So drugs activate the same reward pathways. Now, if you look at this slide, right, you can see here at the bottom, on this axis, this number is 100, right? Now these are basically mice that are feeding. When they start eating, they're measuring the level of dopamine. They start eating, it goes from 100 to 150. Okay, a little bit of a bump there, right? If you look at this one now, this individual takes one dose of methamphetamine, and it goes all the way up to about 1,100. You can't compete with it. You can't compete with it. This is why methamphetamine addiction is probably one of the most difficult addictions to treat. Okay, the three big killers: methamphetamine, opiates, cocaine. In my opinion, those are the three big killers right now. Whitney Houston just died from a cocaine-related event, as far as I'm concerned. That's my opinion. So basically, all of these drugs of abuse. Now, it doesn't matter if it's marijuana, alcohol, which is not a drug, but alcohol itself, cocaine, crack cocaine, opiates, these all increase dopamine levels. Okay, so that's one very important concept to take, that there's only one reward pathway. Now, somebody who smokes marijuana, it may take longer for those changes to occur because it doesn't bump up dopamine levels up here, but it bumps them up a little bit. Alcohol, same thing. But once those changes happen, it's the same changes, okay? One of the key changes that happen in the brain is the following. The dopamine receptors. So all this dopamine is released, right? It goes and binds to a receptor. Basically, the brain says, I am being way overstimulated right now. Take these receptors down. So it downregulates the D2 dopamine receptor population. And that's what this slide shows us, is the more the red you see, I don't know how, hopefully most of you can see this, but the more the red, you can see there's lots of red here, the more the receptors. You can see comparatively there's not much red here, right? There's not much red here. Now notice cocaine, alcohol, heroin, it doesn't matter how you get there. Once those dopamine receptors are downregulated, the brain is adapted, right? Now, here is normal, again, lots of red in the top row, lots of red. In the middle row, this individual, now this is a month after abstinence. Not much red back, right? Not many receptors, because now the brain does say, hey, where'd all that dopamine go? Put the receptors back up. This is 4 months back. You can't really make it out from where you're sitting, but they're just starting to come back. This is normal, lots of red. 1 month after, no red detectable there at all. This is 24 months later, right? So you can imagine it takes a good year to 2 years for these receptors to get upregulated again, okay? Now, how does that enter into the clinical picture? When do most people relapse? Those first 90 days,
Yep.
right? Those first 90 days. And you know, they used to go for that walk on the beach. Not so interested. Want to go to a movie, honey? Nah, not really. You know, they lose the ability to feel the pleasure they used to once feel with the day-to-day kinds of
Right.
things, right? So that's one of the big problems. That's one of the big problems. Now, we launched the Public Education Committee launched an